The scene has been set very nicely for me following this pathology and MRI talk for me to tell you a little about the biopsy techniques in prostate cancer. So for the next few minutes, I'd like to look at the evolution of prostate cancer diagnostics, particularly thinking about the routes and templates for prostate biopsy and how they've developed over time. How should a current diagnostic pathway in 2020 look like? And also look at some issues that have been the cause of quite a bit of debate over the past few years, including the role of targeted or systematic biopsies and the role of fusion technology. It's a good place to start my story here. So this is a copy of Bailey and Love, Short Practice of Surgery, which many of you across the world have probably read. This is a special edition from the mid-1970s, and if you look at the top right corner, this is actually my dad's initials. It's his copy of his handbook that he read at the time. Interestingly, in this whole book, which is about 1,000 pages, there's a little paragraph on prostate cancer, and it's interesting to reflect on how far we have come over the years. If we look at the timeline of things, just to put things into context, PSA only came about into clinical practice in the 1987. So this divides our timeline into a pre-PSA and a PSA era. Prostate biopsy was first described by an open technique in Young's textbook, seminal textbook in 1926. And kind of rectal finger-guided biopsy was then described in 1937. Ultrasound technology in terms of a transrectal route only described in about 1971, and the biopsy protocol by Hodge in his seminal paper in 1989. So over time, you can divide the path of biopsy into an open era through a transperineal route, a digitally guided transrectal biopsy, and then more truss biopsy, which has been around for about 30 to 40 years now. Ultrasound-guided transperineal biopsy has only been done since about 1981, and techniques have refined over time. And more recently, as we've already heard about, in 2017 and 2018 came the seminal papers which firmly established MRI in the prostate cancer diagnostic pathway. So what are routes and templates for prostate biopsy? I mean, Dr. Turner already talked about this from a pathological perspective, which is a transrectal and transperineal route, which I'm going to talk a lot in detail about. We've also got to remember there is a transurethral route and open biopsy, which is pretty much confined to the textbooks now. How do we do a truss biopsy? So this is an outpatient procedure performed under local anesthetic and antibiotic cover. Patients have an ultrasound placed in the rectum where you can have a good visualization of the prostate. And these are typically the sort of pictures you might get. So this is your sort of axial view of your prostate. Your probe will be there where the dark area is, and you get sort of this view of the prostate there. The peripheral zone, very easily accessible to biopsy. The top part of the prostate, anterior part, not so accessible through a transrectal route. This is the sort of sagittal view that you get. See the seminal vesicles at the back, the peripheral zone, and the central zone around the region of the ejaculatory duct. So this is the kind of the typical picture you get doing this procedure. McNeil described these zones of the prostate, and it's very interesting for us and relevant from a truss biopsy point of view that the majority of prostate cancer you pick up will be from the peripheral zones, which is why probably transrectal ultrasound biopsy has been our workhorse for the last few years, because it did give us a good pickup rate for these peripheral zone cancers. Not very easy to access the top part of the prostate. This is a sort of picture you might get with the prostate, and tumor may typically look like a hypoechoic area down in the peripheral zone. And if you see this, this is easy to biopsy. Now, as PSA came up and lesions were perhaps not palpable, it became very important for people to develop protocols as to, in terms of standardizing the biopsy techniques to improve their pickup rates. The initial paper by Hodge in 1989 set up the sextant biopsy, which pretty much describes systematic cause on the paramedian side, on the right and the left of the prostate, and that gave about a 9 to 10% increased cancer detection rate compared to digital rectal guided biopsy alone. The technology evolved, or the template evolved, over the next 5 to 10 years, and people then started realizing that if you add some lateral cause to the sextant biopsy, that your pickup rate for clinically significant cancer increases. So this pretty much led to the 10 to 12 core systematic biopsy, which is very common around the world still at the moment. Then came the concept of a saturation biopsy in 2001. Saturation biopsy is a technique where we're taking an excess of 20 plus systematic biopsies. This was often reserved for patients who perhaps had a prior negative biopsy and the concern of prostate cancer was still high. The problem with doing a lot of biopsies is you have to match up the diagnostic accuracy to the morbidity. The more cores you take, certainly through a transrectal route, the higher the chance of patients developing morbidity from the procedure. What are these comorbidities or morbidity associated with a transrectal ultrasound and biopsy? Well, bleeding. So bleeding will happen in most of patients, either from hematuria, hematospermia, or rectal bleeding. Infectious complications in the systematic review was up to 6.3%, and a small proportion of patients will develop to urinary retention. Trust sepsis is a big concern for urologists around the world performing transrectal ultrasound and biopsy, and this was a very elegant study performed in over 80 countries. This study is about 7 to 8 years old now, and virtually most people were using quinolone prophylaxis. The rate of sepsis was 3.1% in this study of just over 700 patients. And interestingly, or very worryingly, if in causative organisms are found, 60% had resistant strains. The rise in antibiotic resistant organisms is a big concern for us. And certainly that's led to development of further techniques such as rectal swabbing prior to the procedure to detect these organisms and perhaps more accurately target your antibiotic prophylaxis, or perhaps cleaning the rectum with povidone prior to biopsy. This is a recent systematic review that we published in the Journal of Urology just this month, and it looked at the different antibiotic techniques to prevent infections following prostate biopsy. I mean, unsurprisingly, antibiotic is better compared to placebo. If you use a longer course of prophylaxis, it's better than a shorter course. Fosfomycin is a good alternative for fluoroquinolone, and targeted biopsy is much better than empiric prophylaxis. What about transperineal biopsies? Transperineal biopsies can be undertaken using the brachytherapy grid, and this is often termed the mapping biopsy or template biopsy, and this is what a lot of us think about when we think about a transperineal biopsy. So this is a procedure undertaken under a general anesthetic in a theatre environment generally. So what you would generally use is have a brachytherapy stepper. And on this stepper, you would mind this little template that you use for brachytherapy, which looks like this. All of these holes are about 5 millimeter apart, and you superpose this grid onto this ultrasound picture, and that basically allows you to take biopsies of the prostate at 5 millimeter intervals. The transperineal technique gives you exquisite access to the prostate, very good for biopsying the apex, and very good to biopsy the anterior part of the prostate that you can't at truss biopsy. The template biopsy is also the standard that we would use often to compare other biopsy techniques, as was used in the PROMISE study that you've already heard about. This little device here has revolutionized prostate biopsy. This is a precision point device, and it's a freehand way of doing transperineal biopsy, and it's pretty much taken us from doing transperineal biopsies in theatre to now being able to do it in an office setting similar to a truss biopsy. It doesn't really take any longer than a truss biopsy to perform. So this device, essentially, it's a little adapter that you would fit on your ultrasound, on your truss probe, as so. And this looks like a little bit like a cannula, really. And through here, you put your biopsy needle to go into the prostate. And there's a few pictures of basically, this is the device in the rectum. You've got your precision point adapter mounted on. You'd infiltrate some local anesthetic into the perineum. This is the local anesthetic going into deeper around the nerve, neurovascular bundle. And then essentially this needle or precision point device is placed into the rectum, and through this you can take your biopsies. Basically, you can do a template biopsy of the prostate by just having 2 little access points in the perineum, which is fantastic. Very well tolerated procedure. But what template would you use? If you're doing a freehand biopsy, you can't really do a 5mm mapping biopsy. Well, this is interesting, and a group of urologists, pathologists, radiologists got together and devised this Ginsburg protocol, which is now the accepted template to perform a systematic transperineal biopsy. And basically, the prostate is divided into an anterior, mid, and posterior sector, and also a basal sector and bigger prostates. And in each of these sectors, you take 3 to 4 systematic biopsies based on the size of the prostate. So this allows you to take somewhere in the region about 24 systematic biopsies for the average patient, going up to perhaps 38 biopsies in larger glands. Should you do truss biopsies or should you do transperineal biopsies? Well, this has been looked at in a lot of studies. This is a global study showing higher hospitalization sepsis rates with transrectal biopsy. This is a large study from the UK of nearly 500,000 prostate biopsies, again showing a higher sepsis rate with a transrectal approach compared to the transperineal approach. The systematic review also found advantages of the transperineal approach, including reduced bleeding, reduced fever, and improved cancer detection rates. This study is in press in JUROL, and we looked at non-antibiotic strategies for the prevention of infectious complications following prostate biopsy. And again, you can see very clearly that there's a clear favor transperineal approach is much better in terms of reducing your sepsis rates. The quality of evidence, though, is low. So despite having done all these RCTs, they're not of great quality. Is it time to completely abandon transrectal biopsy? Well, Trexit is the term that's been coined for completely abandoning the transrectal approach. And there's a number of advantages for doing that. You reduce the sepsis rate because you completely avoid the rectal route. From an antibiotic stewardship point of view, it is very good. You don't have to give as many antibiotics. You avoid the fluoroquinolone use, which is obviously rising in resistance. It's much superior for the detection of anterior tumors. And because you can transfer it to an office technique using the LA technique now, there's no reason why we can't offer this as a standard procedure worldwide. It does take a little bit of more equipment perhaps, but not like the stepper and the grid that they did use for brachytherapy. So what should a current diagnostic pathway look like? Well, we've already heard about the impact of MRI and the diagnostic pathway. This was the PROMISE study that we already heard about, which showed that the MRI was much sensitive compared to a truss biopsy in detecting lesions. And this was a PRECISION study, which is a follow-on, which showed that the biopsy of an MRI target lesion was much more sensitive than a truss biopsy. This has pretty much led to guidelines recommending the implementation of a pre-biopsy MRI, both in the EAU guidelines, the European Urology guidelines, and the NICE guidelines, which is a UK body. So this is pretty much what we do locally at the Freeman Hospital, and I'm sure a lot of colleagues across the world do the same. So patients coming through for a hospital referral, whilst traditionally a lot of them would have gone for a prostate biopsy, these days you would insert a pre-biopsy MRI, would then offer a local anesthetic transperineal biopsy, which is an outpatient setting, and the patients then come back with the results. This is a good picture from the team at Freeman Hospital about a year ago when we initially started with our transperineal biopsy. We've now completely abandoned transrectal ultrasound in our center and exclusively offer transperineal biopsies. Coming on to these issues of debate, should I perform a targeted or a systematic biopsy? If you look at this MRI, you can certainly see a little lesion here, and you could say, I will target this with a biopsy. The question really is, what about all the other areas? What's the chance of the MRI having missed something there? And if I do add further biopsies or systematic biopsies of these areas, do I increase my pickup rate of significant cancers? Well, what's the negative predictive value of an MRI? So this was a large systematic review that was done over 7,000 patients, and the number is about 10%. So the MRI will miss about 10% of clinically significant cancer, i.e. if an MRI is normal, there's about a 10% chance that there is cancer there that the MRI hasn't reported. If you look at a lot of studies comparing targeted and systematic biopsy, the combination of a target and a systematic biopsy does increase the pickup rate of cancer by about 5 to 10%. This was a systematic review of over 14,000 patients, and they pooled lots of different studies, including prospective, retrospective, and RCT studies. So one of the criticisms of this study, perhaps, that it did have a lot of heterogeneous type of population of patients in this. And this actually showed that a targeted approach was better than a systematic approach. So there's a bit of controversy as to what the best approach is. As Dr. Patel said before, perhaps centers where MRI is a lot better and more developed, the results may be better with a targeted alone approach versus a systematic biopsy. Now, if you do decide to do a targeted alone approach, how many cores should you take? Is one enough? Well, this was an elegant study by Liu performed last year, and it showed that the sweet spot is perhaps about 3 to 4 cores of biopsy. So if you're going to take a targeted approach to a biopsy, 3 or 4 cores is probably the number you should take, which maximizes the cancer detection rate. What do the guidelines say about the targeted and systematic approach? Well, if a patient's never had a biopsy before, the EAU guidelines recommend a biopsy of target and systematic for any lesion that's above a PIRADS 3. Situation's a bit different if someone's had a negative biopsy before, because presumably the patient would have had some form of a systematic biopsy, then perhaps for higher grade lesions, a targeted approach in these patients is enough. How would you go about choosing what you do? Well, the important thing is, as we've said already, it's important to know your local data. I think for units starting off, it might be safest to combine a targeted with a systematic approach, and that's well reflected in the guidelines. Should fusion be used for biopsies? What do you mean by fusion? Well, basically, because we're doing pre-biopsy MRI, at the time of doing the biopsy, you have to look at the MRI and have some form of putting the pictures together to help you guide your biopsy. But the simplest way of doing this is doing it in your own mind, i.e. cognitive fusion, where you look at the MRI and when you put the ultrasound in the rectum, you're looking at the pictures and going into the area where the MRI said there was an issue. So this is cognitive fusion. Software fusion allows some platforms that fuse the ultrasound in real time with the MRI and take you to that target lesion to guide you to take your biopsy. And finally, you can do it all in the MR scanner with an in-bore MRI. So this is what it looks like. So cognitive fusion, you would have a picture of your MRI. This would be the lesion there in the right peripheral zone. You would do your truss. You might see something there or you may not. So you'll be concentrating your biopsies in that area. Number of fusion platforms out there, and basically what they attempt to do, so this would be your ultrasound picture, and superimposed on that would be what the MRI information had given you, and this would be telling you where to target your biopsy. In-bore biopsy with the MRI, this would be your MRI picture. This is a lesion, and you take it at the time of the MRI. This is more time cost effective and takes a lot longer to do as well. Is there much of a difference between the techniques? Well, not really. Systematic reviews haven't really shown the benefit of one over the other. So the message is cognitive fusion is the way to go if you haven't got access to the more software or in-bore techniques. And finally, where are we going next with all this? We've come a long way from the time of a little paragraph in a textbook. Artificial intelligence is coming in the horizon for the prostate diagnostic pathway. There's already multiple applications on the role of AI in prostate cancer pathological reporting. And you can see there's probably not much of a leap of the imagination where these software fusion technologies may soon incorporate AI as well. So in summary, I hope I've given you a little idea of how we've come today. What are the routes of a biopsy? Well, mainly truss and TP, transperineal. We're moving to a local anesthetic transperineal technique, which we should do for a number of reasons. How should the current prostate pathway look like? Where a pre-biopsy MRI is recommended. Should I perform targeted or systematic biopsies? Important to know your own data. Current guidelines would suggest you should add a systematic biopsy if patients have not had one before. Should fusion be used for taking biopsies? Well, in the era of MRI, I would argue that all our biopsies are cognitively fused anyway, and software fusion is promising. Thank you very much for your time.